Welcome to the Mulligan Clinical and Scientific Lectures. This project consists on a series of short lectures on different interesting aspects of the Mulligan concept. Our aim is to promote and provide free education on important topics of the Mulligan concept, contributing to the continuous professional development of colleagues around the world. This episode will be about clinical reasoning in the Mulligan concept. We would like to thank Jack Millerr, one of our Canadian teachers, for his valuable contribution. Jack is a registered physiotherapist. He trained at the University of Toronto and graduated in 1980. He then spent 6 years practicing physiotherapy in New Zealand, where he completed the New Zealand Manipulative Therapy Association's specialty postgraduate program, in 1984. Jack has continued his studies with a Master of Clinical Science from UO in 2008, and a Doctor of Physical Therapy degree from the University of St. Augustine, in 2011. Jack is a founding member of the Mulligan Concept Teachers Association, a director of key clinical skills, an adjunct clinical professor, and works as an advanced practice physiotherapist in Canada.
Hello and welcome to Clinical Reasoning in the Mulligan Concept, brought to you by the Mulligan Clinical and Scientific Lectures. My name is Jack Millerr. I'm a physiotherapist. I trained originally at the University of Toronto in Canada. And then after that undergraduate program, I then wanted to continue the journey, as they say, and ended up spending 6 years in New Zealand, during which time I completed the New Zealand Manipulative Physiotherapy Association's postgraduate diploma program, and had the opportunity to mentor under some well-known physiotherapists, including both Robin McKenzie as well as, of course, Brian Mulligan. Came back to Canada and dragged my New Zealand wife back to this place she so calls a frozen wasteland. And once again, continued on the journey. I did a master's degree at Western University here in London, Ontario, where I live, as well as a clinical doctorate through the University of St. Augustine in the United States. I've had the pleasure of providing some service to the profession, including being the editor of the Canadian Physiotherapy Association's Orthopedic Journal for several years. I was on the executive as well as the president of the Canadian Academy of Manipulative Physical Therapy. And one of my great pleasures is having been one of the founding members of the Mulligan Concept Teachers Association, as well as serving on the executive of that body for a number of years as well. I hold a couple of academic appointments, both at the University of Toronto as well as McMaster University, where I am an adjunct clinical professor. My clinical work is primarily that of an advanced practice physiotherapist, and I have the pleasure of teaching the Mulligan concept, particularly here in Canada, but also internationally as well. Okay, well, let's get started here, talking first of all about clinical reasoning from the perspective of orthopedic manual therapy. And there's a great quote there from Isaac Newton. If I've seen further, it is by standing on the shoulders of giants. And Brian Mulligan openly acknowledges that he too stands on the shoulders of giants, and acknowledges the contributors such as John Monell, James Syriax, particularly Freddie Kaltenborn, but also Jeff Maitland, Greg Grieve, Stan Paris, and Bob Belvey, as people who have contributed significantly to his concept. And the picture on your right-hand side, in case you're wondering who those people are, on your left is Jeff Maitland, and then Stan Paris, Freddie Kaltenborn, and to your right, is slightly cut off in the picture, is Greg Grieve. And that's from the founding meeting of the International Federation of Orthopedic Manipulative Physical Therapy in Montreal back in 1974. So let's talk about clinical reasoning, first of all, from the perspective of traditional orthopedic manual therapy. So first of all, we should acknowledge that it is not just a series of techniques that you do to people. It is a multi-dimensional approach that involves education, yourself, your peers, your patients, collaborating with your peers, behaving in a certain manner, advocating for your profession, being actively involved in research, yes, doing with patients, but also along with that, thinking. And so my challenge to you is, do you truly believe that you incorporate mobilizations with movement into your clinical practice from a sound clinical reasoning foundation, or do you simply use them as a series of clinical tricks? Think about that for a few moments, please. And so with clinical reasoning, it means many things to many people. And it's the proverbial five blind men feeling the elephant. One says it's a wall, one says it's a tree, the other an elephant, etc. And the same thing with clinical reasoning. It's many things to many people. But let's have a look at a couple of quotes from some well-recognized individuals who write and research into clinical reasoning. The first quote comes from Higgs and Jones. Clinical reasoning to them is the thinking and decision-making processes associated with professional practice. Another quote that involves Higgs is that it is clinical reasoning is both cognitive and interactive. Now, it's mostly unobservable. At times, it's automatic and subconscious. It's multifactorial and often context-dependent. Two more quotes. It is data gathering, organization, interpretation, hypothesis generation and testing, critical evaluation of alternative diagnostic and treatment strategies, and my personal favorite from Jeff Maitland is the process of making sense of a clinical encounter. At the end of the day, it's making features fit. Now, in traditional orthopedic manual therapy, the clinical reasoning is built around this concept that movement impairments are often structure-based. And so here's a graphic from Hedgeveld where we start thinking about orthopedic manual therapy with movement impairments, and we can see that it may be relatable to multiple factors: muscle, joint, neurodynamics, viscera, soft tissue. But at the end of the day, it's structure-dependent, isn't it? So with this type of critical reasoning, we see individuals, we observe that they may have a functional impairment of mobility. And we think that this is a restriction, and that may be seen with both restriction of passive physiological movements as well as accessory movements. And often pain may be experienced during movement, but if we look at that movement diagram on your right-hand side, it's that R1, resistance 1, comes on first. Yes, we may have the first onset of pain, P1, but at the end of the day, it's resistance that is the range limiting factor, isn't it? And that resistance, what do we need to do? Well, we need to stretch it out, of course. Those adaptive shortening tissues have to be elongated. And that can be done through a variety of different interventions, such as accessory glides. And those may be in the form of passive accessory vertebral movements, such as PAs in the spine. Or in the periphery, we may apply the concave-convex rule. Or we may choose to do passive physiological movements. And often the movements are in the direction of restriction and often pain. So the direction of your grade of mobilization is driven by your perception of the motion restriction and perhaps the patient's irritability. But at the end of the day, you're making the decisions. And the patient, I'm sorry, is essentially a passenger on the bus. They can pull the cord, as you see there, and decide when to get off, but they really don't get to choose the route an awful lot, do they? And so this type of thinking process follows a test, treat, retest paradigm. Now, I like analogies because I think they help people understand what could otherwise be complicated ideas. So let's look at one of my favorites. You choose to have dinner and you want some spaghetti. And so you put the spaghetti in the pot and you cook it for a while. And after it's been boiling, you think, hey, it must be done. And so what do? Well, you pour it out into the colander, let it cool for a few moments, and you grab a piece and then you realize, oh, gee, I took it out too soon. It's not fully cooked. Well, what do you have to do? Well, you've got no choice but to start over. Because if you try to recook that spaghetti, it just turns into a glup, doesn't it? And so this system of test, treat, retest, it's a fine system. Nothing wrong with it. But at the end of the day, it is using reactive clinical reasoning. You don't know if you did it right or wrong until afterwards, until you do the retest. Now, we're going to be using some terminology in our discussion here. So let's lay the groundwork so we're all speaking the same language. One of the terms that we're going to be using is CSIM, and that stands for the Client-Specific Impairment Measure. And this was described by Wayne Hing, a New Zealander now living in Australia, in one of his papers that he published. And he describes this as it's the client's functionally impaired activity, and the function is impaired by pain. And that might be impairment of active range of motion, such as loss of hip interrotation that's impaired by groin or buttock pain, or impairment of motor function, such as grip that's impaired by lateral elbow pain. Now, important point here is that this is not a pathoanatomical diagnosis. It is not tissue-based. It is a functionally impaired activity. So instead of following that international classification of disease, we're now really working in the international classification of function. So with mobilizations with movement, now we may see a loss of both active and passive movement. But now we might actually see is that pain comes on relatively early in the movement. So we have that P1 now coming on before R1. And it's not resistance to the range limiting factor any longer, it's pain. And so what are we going to do now? Are we just going to push through pain, do the no pain, no gain type of approach? No, we've got another alternative, and that's to use mobilizations with movement. So let's think about the process of application of MWMs. So we start off, first of all, ensuring that there's no contraindications to treatment. We identify that client-specific impairment measure, their functionally impaired activity, the thing that they can't do because of pain. We apply a pain-free accessory mobilization. Now, how do we know it's pain-free? Well, you got to ask the patient, don't you? And so the patient is actively involved in this decision-making process now. We do now, while maintaining that pain-free accessory mobilization, we have the patient now do the client-specific impairment measure, the very thing that a moment ago was painfully impaired. If it is now pain-free and increased in function, we repeat it a reasonable number of times, and we add passive overpressure at the end of range to achieve end range loading, which we'll talk about shortly. After doing a reasonable number, then we take our hands off the patient and we reassess the individual for sustained gains. And if there's a functional improvement of mobility and function, then obviously progress the patient onto self-treatment. So now with mobilizations with movement, the direction and grade of mobilization is not determined by you, the operator, and your perception of joint restriction. It's actually driven by the patient's real-time symptom modification response. So they're no longer the passenger on the bus, they're the driver, aren't they? So now, if we go back to that spaghetti analogy, instead of pouring the spaghetti into the colander, what Brian Mulligan gives you is a long-handled pasta lifter, and you get to reach into the boiling water and pull out a few strands, let it cool for a few moments, have a taste. And if it's not quite done, it's not a problem. You just keep cooking it some more. Or if it is done, you can serve it up. So now what we have here is a test, treat, retest paradigm. So we no longer are using that reactive clinical reasoning, but rather real-time active reasoning based on the patient's symptomatic response. You know you're in the right place, doing the right thing, in the right direction, with the right grade while you're doing it. How? Symptom abolition. Now, we're going to go through this flowchart, and I first of all want to thank Kiran Sapute from India, one of our great Mulligan teachers there, for first of all putting this together, and then secondly, allowing me to share it with you. So let's work our way through this. We start off there in that yellow box. So the patient has a pain with movement or exercise, and we've excluded our red flags. We've done our appropriate medical screening. And we asked the patient, look, well, yes, you've got pain with this movement or activity, but do you think you can continue on? And the patient thinks about that, and they think, well, yeah, maybe yes. Or they have beliefs that this is okay, it's acceptable, and it may be good for them. Well, what we do, well, of course, we don't interfere. We allow the patient to continue on. Or perhaps if the patient stops and thinks, goes, gee, I don't know if I really want to do this. You know, it might be bad. I might get hurt. Well, we could do appropriate patient education, reassurance. And if the patient accepts that and goes, well, that makes sense, sure. Then can you continue on with movement exercise? They say, yeah, I think I can do that. Then, of course, once more, we don't interfere and we allow them to do it. But that's the perfect world, isn't it? And we don't live in that perfect world, because sometimes we get this, where we want the patient to exercise and we ask them, can you do it? And they say, no, that red box. Or despite applying our patient education, the patient goes, no, it hurts too much. I just can't do it. that's when we might want to then incorporate mobilizations with movement. And after a reasonable number, and demonstrating to the patient that it's safe and appropriate to perform that functional activity and that it can be completely pain-free and improved in function, then asking them, hey, can you now take on the role and do exercise? And if they say yes, then once more, we do so, let them continue on. But also, if it doesn't, then it's okay, because MWMs on that day are not indicated. Now, they may be at a later time, but at that particular time, we don't persist on. And so that's a really great clinical reasoning flow sheet. And again, I want to thank Kieran for putting that together and allowing us to share it with you. Now let's work our way through some of the fundamental principles of MWMs. And Brian Mulligan loves these acronyms, and one of them is Crocs. And so let's work our way through each of those letters, starting with the C, which stands for contraindications. And so it's important to appreciate that mobilizations with movement share all the contraindications and safety features of every other orthopedic manual therapy system. We want the absence of infection, active inflammatory disease, metastatic or vascular pathology. Absolutely, we still have all the same contraindications and safety features, but we got one more on top of it, and that is that during the application or afterwards, we never reproduce the patient's symptom of complaint. So it's kind of hard to hurt somebody if you follow a system that says never hurt somebody. The R in Crocs stands for repetitions. You want to do a reasonable number of repetitions. Now, how many? I don't know, like the graphic shows you there. It's up to you and the patient's status. So perhaps we might want to do a fewer number of repetitions or fewer sets of repetitions if we're dealing with a spine problem, or if we're dealing with a more irritable case, or if it's our very first time with the patient, because we don't know how the patient's really going to respond, do we? Or if it's now a less irritable problem, or if we're dealing with a peripheral problem, or we've seen them several times and applied the interventions, they've never had an adverse response, well, we might then want to do a greater number of repetitions. But we always will stop, and after doing a set, reevaluate that client-specific impairment measure to make sure that we are making appropriate gains and not starting to regress. O stands for overpressure. And this allows us to get that true end range loading that can only be achieved through passive overpressure. And so often we can get the patient to do this. Why? Because it takes down their fear, because normally they would have pain with that activity. And if we put them in that driver's seat, then they're going to have a lot less fear of performing that activity. So that passive overpressure allows us to provide true end range loading and stimulate a whole variety of different physiological as well as neurophysiological responses that only occur at end range. The C stands for consent, communication, and cooperation. Now, obviously, informed consent is absolutely imperative, both of the potential benefits as well as risks. We need clear communication of the patient that we're looking for no symptoms. Often the patient comes to us and they've seen other practitioners and they think, well, gee, that hurts a lot, that must be good. And so we have to help them appreciate, no, what we're looking for here is no pain. You need this continual dialogue with the patient about symptom abolition in order for you to adjust both the direction as well as grade of the mobilization component. And we'll look at that in a few moments. But at the end of the day, what MWMs really do is they allow us now to work with the patient, not on them anymore. The patient is no longer the passive recipient of care. They're an active, engaged partner. The C in Crocs stands for knowledge, and you do need a basic physiotherapy knowledge, anatomy, biomechanics, proper assessment, and good knowledge of musculoskeletal medicine in broad terms, as well as the medical masqueraders that we always have to be conscious of. We've got a bunch of different S's. First of all, sustained. One of the great things about MWMs, again, is it allows us to get that true end range and stay there for a period of time, 3 to 5 seconds perhaps. Why can we do that? No pain. And so we no longer need to oscillate in and out of end range. as we're also oscillating in and out of pain, we can sustain these interventions at end range because it is symptom-free. S stands for sensibility. Now, you are always using the patient's symptomatic feedback as the primary decision maker. But along with that, you're still using your manual handling techniques to sense the direction of ease, as opposed to traditional manual therapy that usually mobilizes in the direction of restriction. What I find often is actually the opposite direction. The one that's easy to move is the one that is pain-free and allows improvement of function. S stands for subtle, and so that accessory direction is not universal. It changes between different patients and even within the same patient between treatment sessions. And so often you'll find that minor changes of the mobilization direction may often result in significant improvements to the results. And that acronym over on your right-hand side there, the graphic rather, that less is more is quite true. S stands for sense, common sense. And we need a sound clinical reasoning approach at all times. Please do not go back to the 3 sets of 10 recipe approach. Treat every patient as an individual. Use common sense in your selection of techniques, the progression of those techniques, and knowing when to stop. And S also stands for skill. Strongly encourage you to seek out proper instruction from an accredited Mulligan concept teacher. You can find them listed at www.bmulligan.com. We teach internationally. These people have all mentored directly under Brian Mulligan and passed a rigorous examination process in order to become accredited teachers. Let's look at another acronym now, PILL. P stands for pain-free. Mulligan rejects this no pain, no gain philosophy. Now, if symptoms are reduced but not completely abolished, then again, often small little changes to that vector of the mobilization may render them completely pain-free. We'll often also find that a painful translatory glide in one direction, say medial to lateral, will often be pain-free in the exact opposite, say lateral to medial direction. I stands for instantaneous. There should be an immediate positive change to the client-specific impairment measure. The symptom intensity in ideal terms is completely abolished, but we can sometimes settle for significant decrease of symptoms. But most importantly, along with that, we want improvement of their functional performance, whether it be range of motion or motor function. The L, the 2 L's, stand for long-lasting. The functional performance of that client-specific client-specific impairment measure should demonstrate improvements during the techniques, but also be durable over time. My goal is to have at least 50% retention of my gains from the last intervention treatment session with my patients. And if I get that, I'm pretty happy. Now, of course, I'd love to have even more, but if I'm not at least gaining 50% of, or retaining 50% of my gains, then I've got to stop and think if I'm really doing the right thing and may need to change something in the formula. Right, now let's start looking at some of the variables of application in mobilizations with movement. And I borrow this graphic from Bill Vincenzano from the University of Queensland. Along the horizontal axis, we have a couple of variables where we can be in the preferred treatment plane or out of the preferred treatment plane. And on the vertical axis is the amount of force of the mobilization intervention, with increasing amounts of force being on that vertical axis. And the line is success. Now, we could be applying a fair bit of force, a significant amount of mobilization force, but if we're not in the appropriate treatment plane, then I'm sorry, what we get is failure, and often an injured patient because of the amount of force that we're applying to that patient. But if we modify the vector of our mobilization force and now are in the treatment plane, what we'll find is we really don't need an awful lot of force to achieve success. So of these 2 variables, of the amount of force as well as the direction, it's usually better to try to change the direction. So if the mobilization does not abolish or at least substantially reduce the typical pain, that client-specific impairment measure, then we suggest that you might want to adjust the vector. And Brian calls this constructive fiddling. I refer to it as the accessory direction of preference, because that's what it is. It's still an accessory motion, but it's based on the patient's response of their preference with pain abolition. Now, you can still adjust the force, but please, again, more is not always better. But at the end of the day, if pain with function still continues, then again, on that day, it's not indicated. Further to that treatment plane concept, let's just clarify what that is. So the treatment plane is this concept of an imaginary three-dimensional plane that lies across the concave surface of the joint partner. Now, it can be quite variable dependent on genetics, patient's growth, injuries, and the mobilization component of mobilizations with movement is always applied parallel, perpendicular, or if we're doing rotation, about an axis that's perpendicular to the treatment plane. Great. But there's something else happening with mobilizations with movement, and that is the movement. So because MWMs involve the patient's dynamic movement through range, then something interesting happens. And so let's say that we have here a concave convex joint, and there it is laid out for you. And on the top graphic there, the treatment plane lies across the face of the concave partner, and the joint is quite flexed there. The convex bone is hanging down. Now, if the patient now moves from that top graphic to the middle one, where they start to be moderately flexed, the convex bone is moving. And then in the bottom graphic, the joint is now completely extended. But the question I'm going to ask you, in any of those situations, has the treatment plane changed? Well, the answer is no, because the concave partner has stayed stationary. Great. And so here's a good example of what that might look like. So here we have a mobilization with movement for ankle dorsiflexion, where we do a posterior glide of the talus. That's the start position on the graphic on your left-hand side. And the red line would be the treatment plane across the face of the tibia, the concave partner. The operator is now using his thigh to push the foot up into dorsiflexion. And what I'd like you to note there is that the treatment plane in red hasn't changed, and neither has the vector of force in blue. Why? Because the treatment plane has not changed whatsoever. Why? Because it's the convex partner that is dynamic. But let's look at a different situation. Now let's say that the concave bone is the one that is moving. So here we have, again, that concave convex joint, but now we reverse things. And in the top graphic there, the convex bone is going to stay still. And you can see that in red, the treatment plane lies across the face of the concave partner, and it's quite flexed. Now, as that now is moved up into semiflexion, you can see that the treatment plane has changed quite a bit. And in the bottom graphic, when the joint is completely extended, you can see that it has almost changed 90 degrees. And so as such, the treatment plane is dynamic. And so if that's the case, guess what? You've got to be dynamic too. So now let's look at this MWM in weight bearing. And so you can see here that the belt is producing the mobilization force to that tibia. And it is parallel to the treatment plane as formed by the to the tibia. But as the patient lunges forward, now the treatment plane is dynamic. The treatment plane is now oblique. And what does the operator have to do? Well, they essentially have to do a squat in order to maintain that parallel vector of force to the dynamic treatment plane. So a little clinical pearl here is if you're doing a technique, an MWM, and halfway through the technique, the patient says, ow, that hurts again, you may want to stop for a moment and ask yourself, hey, which bone am I mobilizing? And then don't worry about that. Ask yourself, what bone is the patient moving? And if it's the concave partner that's dynamic, then you've got to be dynamic along with it. Now, some final thoughts here that I want to throw out to you, and this comes from a quote from Louis Gifford, and it's a great one. New synaptic learning would be of little use to a patient if it were associated with lying face down on a therapist's couch while mobilizations were performed on their lumbar spine. However, if the patient can see and feel that it's possible to bend forward with no pain and hence start to learn pain-free movements, then this could have enormous functional significance. Experimenting with various mobilization techniques while asking the patient to move can produce better and less painful movements. Some familiar examples of the sorts of techniques that can be used include so-called sustained natural apophyseal glides, SNAGs, and mobilizations with movement, MWMs, Mulligan, 1999. Used in the right context, for example, with lots of explanation, combined with therapist assistance and reassurance. These types of techniques can sometimes help patients challenge fear or restricted movements. And I think that's a wonderful quote, because that's what we're really doing. We're helping the patient to engage that pain-impaired functional activity, reduce their pain, and help them move on with life again. All right, well, that brings us through to the conclusion of this presentation. I hope that it's been of interest to you. I really do want to thank Francisco Neto, the organizer of the Mulligan Clinical Scientific Lectures, for the invitation to present this information to you. I also do want to thank Brian Mulligan for his tremendous contribution to our profession, as well as his kindness and mentoring. Thank you very much for your time.